Very good. I think that it was a great presentation. I think that we have to discuss a little bit further after this talk on the settings of congenital heart disease here in Alger. And I want to hear more because we have the same problem in Spain. Believe it or not, in Spain we have 19 centers of cardiac surgery with a patient population of 48 million. So we have the same problem. So I think that it's very pertinent. But we're going to talk about something a little bit more tangential. We're going to talk about arrhythmias in the postoperative period. I'm going to be brief because we can open the panel for discussion later. And I think that the most important thing is to realize, again, that besides mortality, there is other important things that happen after surgery. And arrhythmia is a very important problem. Up to 40% of our patients have arrhythmias, significant arrhythmias in the postoperative period. With the improvement of surgical techniques, with the improvement of postoperative management, we have decreased the incidence of arrhythmias. But complex surgeries, long extracorporeal times, and a lot of comorbidities make arrhythmia a big problem. We have to understand that our patients are complex. Surgery by itself, it's a big substrate of arrhythmia. CHD, congenital heart disease, associates arrhythmia. There is a specific congenital malformations that we all know that are associated with certain types of arrhythmia. Very well known that Epstein malformation has concealed and abnormal pathways that produce Wolff-Parkinson-White. Same applies to heterotaxia syndrome and so on. So there is an association between arrhythmia and congenital heart disease. But the interesting thing is that in the postoperative setting, we have continuous EEG monitoring, we have blood pressure monitoring, we have CVP, central venous pressure tracing monitor, that give us a lot of information. And the combination with new treatments and the pacemaker wires, the treatment of arrhythmias in the postoperative period is relatively straightforward. As I told you before, heart surgery is a complex process, a complex journey. And there is several things that happen in this journey that increase the incidence of arrhythmia. We have problems with electrolytes. We have direct damage to the node and to the heart with higher incidence of arrhythmia. We have changes in volume and in pressure that will stretch the heart and will increase the incidence as well. We have inflammatory response that happen during the pump that triggers arrhythmia. We have hypoxia. We have exogenous and endogenous surge of catecholamines. So all of those things participate in the etiology of this problem in the postoperative period. And as I told you before, there is a direct association with certain types of congenital heart disease and certain types of surgeries with specific arrhythmias. We all know that VSDs and complete atrial ventricular septal defects associates higher degree of a complete AV block, that Fallot also associates a complete AV block or junctional ectopic rhythm, and so on. There is direct association between heart problems and arrhythmias. But the beauty is that we have in our hands the tools to minimize the impact of arrhythmia. We have our clinical experience, we have expertise, we have the 12-lead EEG available in our units. As I told you before, we have lots of monitors with a lot of information that can give us very important information in the etiopathogenesis and the response of the arrhythmia. And then there is other important things such as the pacer wires. The pacer wires that all surgeons should put into our patients give us information that will help us with the diagnosis of arrhythmia. One of the important things that we normally don't put much attention on is the CVP, the central venous pressure tracing. the anesthesiologists play close eyes to the waveform of the CVP, but sometimes in the postoperative period, we don't pay too much of attention. And the CVP waveform gives us a lot of information in the diagnosis of arrhythmia. Remember, the atrial contraction is represented with a A wave in the CVP, and this is, for instance, what happened on the dissociation, that we have canon A wave on the CVP tracing. So take a look at the CVP tracing when it comes to the diagnosis of arrhythmias. And then the other important thing is the 12-lead EKG that we all know about, but more than the 12-lead EKG is what we call the atrial electrocardiogram. The atrial electrocardiogram is the representation of the EEG utilizing the pacer wires. We take one of the atrial wires and we connect it to the EKG machine, and we have a very nice representation of the P wave on the surface EKG. It should be the standard of care on all patients coming out from the OR to have an atrial EKG in the postoperative period. Obviously, only if your surgeon put pacer wires on. And this is, I think, the most important slide, is how we diagnose and how we classify arrhythmias. And I think that everything in ICU has to be very simple. And the more simple you are, the better results that you will have. And the way to classify arrhythmias is between slow bradyarrhythmias or fast tachyarrhythmias. If we focus in bradyarrhythmias, in the postoperative period, we only have two: sinus node dysfunction or different degrees of complete AV block. And in the other hand, in the tachyarrhythmias, and I'm going to focus on that later, we have two important groups: the reentry tachycardia, the so-called SVTs, or the automatic tachycardias, the junctional ectopic tachycardia. And those are the most common and the very few arrhythmias that happen in the postoperative period. So let's talk first about the bradycardias. Bradycardias are straightforward. Bradycardias are usually secondary to something that the surgeon has damaged. And the treatment of the bradycardia is normally a pacemaker. So there is not much to say about bradyarrhythmias. We can have sinus dysfunction, and that will be in the setting of a Fontan circulation, very common on the Senning operation. And in the other side, we have complete AV blocks. And the complete AV blocks are either congenital or secondary to surgery. And the complete AV block in the setting of surgery, it's relatively frequent, but normally they resolve during the first 2 weeks immediately post-op. If they don't resolve, what you have to do is to put a pacemaker. The sinus dysfunction is very common after a closure of ASDs, sinus venosus type, and the treatment is time, patience, and sometimes you have to put a pacemaker with an atrial wire just to restore the synchrony, the appropriate synchrony, and the appropriate heart rate. And in the other hand, what we have is the AV blocks. It's not time to spend focusing on what is a complete AV block, but here you have the different degrees. Obviously, we all know what's a first degree AV block. It's a prolongation of the PR interval. Then we have the second degree AV block, the Movitz 1 or Wenckebach, where the PR interval gets slowly widened until it blocks, and then we have advanced second degree AV block, and at the end, the third degree AV block. Second and third degree AV block in the setting of the postoperative period, away from 2 weeks from the surgery, is an indication, a clear indication of pacemaker. And interestingly enough, to see that, because when there is AV dysynchrony, what is happening is that since we lose the AV sequential pacing, we are losing 30% of our cardiac output. That's why it's so important in the immediate postoperative period to restore AV synchrony, because in the immediate postoperative period, the presence of AV desynchrony is associated with a loss of 30% of the cardiac output. But let's focus into tachyarrhythmias. Tachyarrhythmias are classified in two different ways. One is anatomical classification, which I think it's very useless, and more a physiological classification. When we talk about anatomical classification, it's pretty straightforward. We talk about supraventricular tachycardias or ventricular tachycardias. And when we focus into supraventricular tachycardias, we have two types. The ones that are originated in the atriums, or the ones that are originated in the node, in the AV node. And applying a pure anatomical classification, we can tease apart all the types of tachyarrhythmias. We have supraventricular tachycardias. From those ones, we can take the ones that are initiated in the atrium, and here we'll have the atrial fibrillation, atrial flutter, the atrial tachycardia, or then the ones that are initiated in the AV node. And the AV node, we have re-entry tachycardias and other accessory pathways. If we progress a little bit more into the diagnosis, one of the important things to differentiate between both arrhythmias is paying a close attention to the EKG. And we know that if we take the EKG into account, the tachyarrhythmias that are originated in the atrium, they will have more peace than QRSs. Those initiated in the conduction system normally will have one-to-one conduction. And those initiated in the ventricle will have more QRSs than peace. So with this easy diagram, you can approximate yourself to the proper diagnosis of arrhythmias. But probably the most important classification is the physiologic classification, because it has implications into the treatment. And this is to differentiate between re-entry tachycardias, those initiated by anomalous pathways, compared to the automatic tachycardias, those initiated by anomalous focus that triggers arrhythmia. And this classification is very important because it has implications into the treatment. The re-entry tachycardias respond to cardioversion, both electrical or pharmacological. But the automatic tachycardias, they do not respond to cardioversion. Unfortunately enough, the most typical postoperative tachyarrhythmias are the automatic ones. Therefore, we have few things that we can do pharmacologically to treat them. It's easy to differentiate. If you see that re-entry tachycardias, they have an on-off phenomenon, sudden onset, sudden termination, and the automatic ones are progressive. They have a warm-up phenomenon. So there's a very different onset of the arrhythmia. So again, tachyarrhythmias, if we focus into atrial tachyarrhythmias, we can have ectopic atrial tachyarrhythmias, multi-atrial tachyarrhythmias, and atrial flutter. If we apply this classification, it's very easy to tease them apart. And we have to understand the mechanism in order to treat them. This is an atrial flutter. Atrial flutter, it's very easy to diagnose. Regular rhythm with the typical tracing of the atrial flutter. What's the implication? Again, the loss of the AV synchrony. And that's something that we have to restore. Atrial fibrillation, it's 1 degree even further than the atrial flutter. We have loss of synchrony and irregular heartbeats. Very easy to diagnose as well. Atrial fibrillation, so you have desynchrony and rapid response into the ventricle. So very, very hemodynamic and stable in the immediate postoperative period. Again, atrial fibrillation compared to atrial flutter. Atrial flutter normally better tolerated regular rhythm, atrial fibrillation, abnormal EKG tracing. Reentry tachycardias, those using anomalous pathways. The most common one, the Wolff-Parkinson-White. And we have to differentiate between those that uses anomalous pathways that are conducting anterograde from the AV node and retrograde through the pathway, or those conducting anterograde through the pathway and retrograde through the AV node. This difference between conducting anterograde through the pathway is that what it gives us the typical tracing of the Wolff-Parkinson-White. Remember the Wolff-Parkinson-White, there is a delta wave that it's only a slow activation of the anomalous pathway. Remember, orthodromic, meaning activation through the normal AV node and retrograde conduction through the pathway. And antidromic is conduction through the pathway and then retrograde conduction through the AV node. So accessory pathways, this is the typical activation of the Wolff-Parkinson-White. You have slow activation through the pathway and then activation through the ventricle that gives you this delta wave. And then we can complicate the arrhythmias. AV node reentry tachycardias are very complex, are very unusual during the postoperative period, and I don't think that we have to pay much attention to that, but I think that it's interesting that we have to diagnose them. It's probably difficult to see, but this is a fast, short QRS tachycardia with a long QRS-P interval. So this is a very complicated tachyarrhythmia, AV node reentry tachycardia called a PGRT or Kummel tachycardia. Those are very unusual tachycardias in the postoperative period. Probably the most important thing is to realize that the most common arrhythmias are the automatic arrhythmias. And inside the automatic arrhythmias, the most frequent one is the junctional ectopic tachycardia. Those are arrhythmias that respond to an anomalous surge of catecholamines. They are associated with a high degree of usage of inotropes, long pump times, and adrenergic discharge from fever, pain, so on. And the most common one is the junctional ectopic tachycardia. It's a fast, regular tachyarrhythmia. It's more than 170 beats per minute. There is always AV dissociation or retrograde conduction with a 1-to-1 QRS to retrograde P waves. And this is the typical tracing of the junctional ectopic tachycardia. It's a narrow, complex, regular tachyarrhythmia that if you take a look on the atrial EKG, this is on the right side of the screen, you will see the atrial EKG. That is putting a pacer wire into the EKG representing the P wave. So you have the QRS, and after the QRS, you can see a retrograde P wave. And this is the common EKG tracing of the junctional ectopic tachycardia. And then obviously we have ventricular tachycardias that are very hemodynamic and stable in the setting of the postoperative period. Ventricular tachycardia, which is somehow relatively stable for a period of time, and then we have the ventricular fibrillation, which is a storm and something that it needs rapid attention in the immediate postoperative period. So I think that gives you a brief overall, and for the sake of time, I will stop here, but we have to realize that arrhythmias, and especially tachyarrhythmias, are very common in the postoperative period, that they have an associated morbidity and mortality, and we have to be very, very careful into the diagnosis. We have to approach very sequentially to the classification, and we have to be very diligent in treating the arrhythmias. Thank you very much.